So welcome to the webinar on sexual health and youth mental health, focusing on interventions and case studies. I'd like to begin by acknowledging the traditional owners of this land on which we meet today. I would also like to pay my respects to elders past and present. Hi everyone, I'm Georgina Cox and I'm a Research Fellow in Suicide Prevention here at Orygen, the National Centre of Excellence in Youth Mental Health, and I'll be the moderator for the webinar today. This is the last webinar in this series and we hope that it will be useful for you working with young people in the future. Okay, so it's my pleasure to introduce Brian O'Donoghue. Brian is a consultant psychiatrist and a clinical research fellow at Orygen, the National Centre of Excellence in Youth Mental Health, where he leads a multidisciplinary team in providing treatment for early psychosis in young people. His research interests are in the delivery of effective treatments for psychotic disorders with minimum side effects or harmful effects. He completed his medical degree at the University College in Dublin, Ireland, and obtained a master's degree in epidemiology and public health from the University of London. He has also received a PhD from University College Dublin on the epidemiology of psychotic disorders, and he's co-authored over close to 50 publications in youth mental health. So I'll pass you over to Brian for this webinar.
Thank you very much, Georgina. So what this presentation is going to follow on essentially from the webinar from 2 weeks ago, which looked at sexual health. And today we're going to look at a number of case vignettes, and through that, and then look at how we might manage particular situations. So just to give a summary of the previous talk, which really looked at and I suppose identified that in a youth mental health setting, the young people that attend are a diverse group in terms of sexual identity. Approximately 55% of people identified as heterosexual, and also that also a diverse group in terms of gender identity. So just under 10% of people identified with a gender different to which they were assigned at birth. And also we looked at a number of different factors within sexual health and focused on sexual dysfunction and also high-risk sexual behaviours. What we found was very high rates of sexual dysfunction. Approximately 40% of young people presenting with clinical levels of sexual dysfunction, and this had a negative impact upon their sexual experiences, but also impact upon their compliance and attitudes towards treatment. We also found that high-risk sexual behaviours, such as multiple partners or engaging in sexual activity without contraception, being quite high as well. And following from that, also the consequences of high-risk sexual behaviour, such as unplanned pregnancy and sexually transmitted infections also being common as well. The other thing that stood out from one of the studies that we did was that this was a trans-diagnostic issue, so this is more of an issue for youth mental health, as opposed to being an issue for people with psychotic disorders or depression. It's actually across the board for all disorders. So if you're working in youth mental health, this is going to be an issue for you, and it's a prominent issue for clients, hence the webinars today. So what we're going to go through a number of cases. We're going to go through 2 cases, but we're also, for one of the cases, going to go through different kind of time points, different scenarios. And because clinicians who will be attending this webinar might be working in different specialties, such as psychosis or mood disorders or personality disorders, what I've tried to do is, while there's a particular case, what I'll do is I'll also talk about what we do if, say, for example, a sexual dysfunction was caused by antidepressants as opposed by antipsychotics, to try and make it applicable across the board. And as mentioned, if you do have questions, please type them in as we go. And then when I finish the section, I'll check across and see if there's any questions or things to be clarified. So in terms of the first case, what we're going to talk about is a young adult with a history of psychosis. So John is a 22-year-old male who experienced the first episode of psychosis 8 months ago, and this episode actually required an involuntary admission because of the level of persecutory delusions that he had. They believed that his family and partner were trying to poison him, and he was constantly monitored by cameras. He was also experiencing auditory hallucinations, which are a derogatory contrast. He was so distressed by these experiences that he contemplated suicide, and hence an involuntary admission was required. So that's kind of that's the initial episode. And during the admission, he was initially commenced on risperidone, but he only experienced a partial response to psychotic symptoms. He also got side effects, and he gained about 5 kilograms in weight in just a few weeks. As a result, the antipsychotic medication was switched to amisulpride, which should be a slightly more potent antipsychotic, and the dose was gradually titrated up to 600 milligrams, which would be a medium to high dose of amisulpride. And following this, he experienced a full resolution of psychotic symptoms and gained insight into his mental health disorder. And he was discharged, and after a few months, he returned to work part-time and started to re-engage socially. So he was making a good symptomatic and functional recovery. And I suppose I'm giving this background cases to start have you thinking that this may be something that you'd be case managing in the community. And at this particular time and point we're going to address, he's currently taking amisulpride 600 milligrams, and he reports being compliant with medication. He very occasionally misses a dose and doesn't notice any ill effects to his mental health when he does miss a dose. And he just takes medication the next day as prescribed. And he has experienced some additional weight gain with amisulpride, approximately 3 to 4 kilograms, in addition to the weight gain that he experienced with risperidone. So now, as mentioned, he's discharged, and he's now in a review. In the last review with his case manager and his doctor, he brought up a concern that himself and his partner have been arguing more recently, and he describes feeling distant from her. And he also revealed that his partner wanted to resume a sexual relationship, so they've only had sex on a few occasions over the last 6 months. And since his episode of psychosis, John described that he has lost interest and desire in sex. And on the occasions that he did have sex, he found it difficult to achieve and sustain an erection. So what he's describing there is sexual dysfunction. So I suppose if this may be a clinical scenario that you've encountered, it may not be, and the other factor why sometimes it doesn't come up, sometimes people may not ask about it, but as we demonstrated in the last webinar, about 40% of young people have clinically relevant sexual dysfunction. So a similar scenario to John's is actually very common across youth mental health disorder clinics. And the sexual dysfunction can be there can be a number of causes, as we previously mentioned in the previous webinar. For example, antidepressant medication and antipsychotic medication can cause it. But it's always good to think broadly and to think about the potential causes of sexual dysfunction in this case. So if we look at them, one is the obvious one, which is antipsychotic medication. And we know that a side effect of this medication is raised prolactin, so hyperprolactinemia. And in particular, it's very common with amisulpride. So we commonly see it. In males, it presents with sexual dysfunction, and similarly in females, but also with changes in menstrual cycle as well in females. So that's one, in this particular case, a very obvious but possible cause. But also, the other thing is that we also have to consider is that depression following an episode of psychosis is very, very common as people come to terms with what's happened, and also the impact it's had on their life and their functioning. And in particular, what stands out in John's case is that there's a decreased interest and enjoyment in sex can be actually a component of depression. So it's always important to keep that in mind and ask about subjective mood and enjoyment in other activities as well. Also, the possible negative symptoms of psychosis. So again, this can occur in the aftermath, in particular even when positive psychotic symptoms have remitted. And part of the negative symptoms of psychosis, people can actually result in a lack of enjoyment or initiation of activities that previously brought pleasure. So when people do describe a lack of enjoyment or lack of drive or interest, it's also important to assess for negative symptoms of psychosis. Other symptoms might be kind of asociality, not going out with friends, or also, for example, you might see poverty of speech or content as well. Doesn't seem to be the case in this scenario. He's resumed contact with friends and working, but it's always good to consider that as a differential. Also, we've noticed as well is that from the medication there's been a change in his body weight. So this in total he's gained about 7 or 8 kilograms of weight. And this can have a big impact on people's self-esteem. So this as well then can have an impact as well on their confidence and issues. So it's important not to neglect that and ask very directly about that as well. Other issues, again, that's very important not to, I suppose, it's very important to look for and consider, is that we can see sexual dysfunction when in medical disorders such as diabetes and hypertension, but also in vascular disease associated with smoking. So it's very important to ask about these things. And also we know that people with mental health disorders are much more likely to actually develop diabetes as a side effect of medication, but also sedentary lifestyle and poor diet, and also vascular disease because of the high level. We see much higher levels of smoking in young people with mental health disorders. So you can see there, it's important to have discussion about, there's a number of things to assess for, and while it's very common side effect of medication, it's important that it's not just automatically assumed that it's related to medication. So the next step is a number of investigations. Oh, and also an important factor as well is about substance use and alcohol. And again, that's another very common cause of sexual dysfunction. Again, it wasn't in the actual vignette, but it's very important to ask about that directly, because we know that there's an association, obviously, between substance use and mental health disorders, and they commonly co-occur. And in particular, for example, with both substance use and smoking, it's a good opportunity to intervene and give people information about the association with that and sexual dysfunction, and that can be a motivating factor to people to reduce either smoking or substance use and develop more kind of healthier lifestyle habits as well. So it is a good opportunity actually to intervene, and not a lot of young people would be aware of those associations as well. So actually, and we might just take this opportunity to look and see, so there's a range of antipsychotic medications. So which ones are more prominently associated with sexual dysfunction and which aren't. And I suppose the ones that would stand out that are strongly associated with high levels of sexual dysfunction are risperidone and also amisulpride. So you can see there with risperidone, the prevalence ranges between 60 and 70%, which is very, very high, and also with haloperidol, but that's used less commonly now. There are some medications that actually are deemed to be prolactin sparing or have a lower propensity for raised prolactin. And that's aripiprazole, which is one of the newer antipsychotic medication. It's a partial dopamine agonist, so it has a different mechanism of action than the other antipsychotic medications. And also quetiapine as well. There's a limited number of studies, but they've indicated that there's a lower risk of sexual dysfunction. So and again, we'll talk about the strategies in a moment for this client, for John, but one of them might be actually switching them if it's appropriate. And as I mentioned, in this particular case, the client, the young person, isn't prescribed an antidepressant, but again, this might be a scenario that you see clinically in the person's prescribed antidepressant. You can see here the different prevalence rates of sexual dysfunction with different classes of antidepressant medications. The commonest ones that we prescribe are SSRI medications, and they can actually affect all different phases of sexual activity, from decreased libido and delayed orgasm being the most common. But about 60 to 70% of people will actually report these side effects with the medication. So it's even high, well, it's as high with antidepressant medication. And commonly we see psychosis and depression co-occur, so it's not uncommon for people with psychotic episodes to actually also be prescribed an antidepressant. So again, something to be very, very mindful of. We see venlafaxine is an antidepressant we tend to use at least second line, perhaps when an SSRI hasn't been effective. And again, that's also got a high rate of sexual dysfunction as well, with decreased libido and delayed orgasm associated with it as well. Mirtazapine, less so. It's got a different mechanism of action, but still about a quarter of people experience sexual dysfunction with it. And the tricyclics and the MAOIs are prescribed less frequently, but they still have the associated side effect. So if we look back and we, in this particular case, and I suppose if you're to imagine that John, you were case manager or doctor for John, you'd be thinking, firstly, how am I going to manage this? Now that you've asked about it, you need to either give some advice or support the person with this either side effect or with their sexual dysfunction. So I suppose the first thing to consider is that it's appropriate to do some investigations. So as mentioned in the history, there's more details that are required in the history, such as whether they're a smoker, and if so, the quantity of cigarettes, and also to take a detailed alcohol and drug use history as well. As mentioned, the serum prolactin that can be associated with the medications, so that's important to measure because that can give you a good indication whether it's related to the medication or not. And to screen for diabetes as well, a fasting glucose test as well. And for all these things, it depends on what facilities you have in your clinic, access to medical staff, or whether you do this in conjunction with the GP as well. So if we look into actually for the management of this sexual dysfunction, so I suppose firstly, if we now kind of for this particular for this slide here, this scenario, if we assume that it could be related to the medication, there's a number of different options that you could do. The first one is that it may be related to dose. So some side effects are dose dependent and some aren't. And there's no kind of clear rule about it. So one of the only ways to find out is actually trial and error or by experimentation, really. And the first option is actually to reduce the dose. And this would perhaps be appropriate in John's case, as he's been well now for a number of months. And we'd often, at that stage, try and reduce down the dose of medication to find the minimum effective dose for the maintenance treatment, because that may actually be different than the dose that's used in the acute setting. So that's important because that might either alleviate the problem or it might actually just reduce the problem. If it's appropriate, you might think about switching the antipsychotic medication to a prolactin-sparing antipsychotic, as I mentioned, such as aripiprazole. Obviously, with that comes with the risk when you switch medications. There's a risk of relapse with that, and similarly with reducing dose as well. It's important to do the reduction slowly and monitor the mental state during that time, and make sure that everyone around the person is aware that the dose can be reduced, and to be mindful and watchful for symptoms of relapse. There has been a Cochrane review done on this topic, how to manage sexual dysfunction associated with antipsychotic medications. One of the things that they suggest or say is a possibility is what's called drug holidays, where people actually take a break or don't take their medications for a few days if they know that they're going to be spending time with a partner and want to engage in sexual activities. But there's very little evidence around this, but it is one of the recommendations that they suggest. And also that has to be done again if it's safe to do so in regards to the medication. Also if the above aren't successful or they're not feasible, so for example, if someone's is very vulnerable mental state, so any changes in their medication tends to result in relapse of symptoms, then it mightn't be appropriate to make any of those changes. So one option would be to consider commencing a medication such as sildenafil, which is the brand name's Viagra. And again, there's been a small number of trials looking at this. I think there's only been 2 or 3 trials looking at it, very small numbers. But indications are that this could potentially be an effective medication. And I have used this clinically in particular with young males who are prescribed antipsychotic medication and want to engage in sexual activities. And they have reported that it has overcome with the side effect. So I think it's an important option to think of, because what we want to do is, for a period of time after the first steps of psychosis, is to ensure that the young person is compliant with medication and to minimize side effects, and because this has a big impact on the quality of life and the relationships as well. And that might be, again, that's a kind of a service level decision about whether that's prescribed directly from medical staff within the youth mental health setting, or whether it's something that actually the GP will be involved in as well. And I think in regards generally with sexual health and young people with mental health, so it is good to involve either a sexual health nurse or a GP as well. Other important things that it would be very important to talk about with both John and his partner is psychoeducation around this being a side effect of medication. And that's important because it's quite common that actually people aren't aware. They mightn't actually draw the conclusion between the two. They may not have been informed about it when the medication was started in the acute setting. And without knowing this, either John or his partner might make a number of assumptions about, and this can lead to kind of difficulties within the relationship. So it's important to discuss it. It's important, and important to feedback what you think is causing the sexual dysfunction. And it's also then important to relay the message that this tends to resolve when medication is discontinued. And what we usually recommend is antipsychotic medication to be continued for 1 to 2 years following remission of symptoms if they've had a single episode. So it's an important message to give that if we can't do anything to help with the side effect, that it most likely will be time limited, and there'll come a time when there'll be a plan for the medication to be discontinued. Okay, so we're going to move on to the second case now, which moves over, like we look at this case in particular, I suppose, a few different time spans as different issues come up in regards to sexual health. But I'll just check over and see if any questions. So no questions have come in. To do, if there's any things you wish to clarify, please just email them in. So we're going to talk about a case now of Amy, who's a 17-year-old female, and we're going to look at Amy's case over 3 different time points as different issues come up. So this is a young female who's been admitted with a first episode of mania, with also psychotic symptoms. The main issue is mania and disinhibited behaviours. And what for Amy, she'd been living in out-of-home care with a foster family, because her father had passed away and her mother suffered with a mental health disorder and had poor functioning. And she's brought to the emergency department by police and found to be in an elated and disinhibited state. Prior to leaving the foster home, she was found to kind of exhibit a number of unusual behaviours, such as being very flirtatious with the son who was living in the house, who was age 19. And ultimately then she appeared to kind of run away. They report, and the foster family reported that prior to this she hadn't been sleeping, was more energetic than usual, and had exhibited some unusual behaviours. So she was found in the inner city by police, and due to her mental state, she was also unable to give an account in the previous few days. So this is a scenario that we would often, possibly, unfortunately, see in our inpatient units, and there's a number of factors that need to be addressed in regards to her sexual health. So obviously, there's a number of factors that need to be addressed in regards to mental health and kind of stabilising her and commencing treatment. But we're just going to focus now on her sexual health. So one issue is, of course, a very important one, is kind of assessing her vulnerability in the acute inpatient unit. So this is a young female who's come into a youth mental health ward, or she's age 17, so she may get admitted to an adolescent unit, or it actually, depending on beds, could be an adult unit. So it's important to assess her vulnerability. Also, she's in a disinhibited state, in a very vulnerable state. And also the mixing with males on the ward, whether she's at risk to that. So that's one of the first things to discuss early on, as soon as she's admitted to the ward with nursing staff. Also, it brings in another issue, and that she's under the age of 18. So it's very important to involve the guardians, parents or guardians in these scenarios as well, because we'll talk through there's a number of issues that will need to be addressed, or the number of concerns in regards to her sexual health. And then the other issue is that we kind of essentially need to make an assessment whether she can provide informed consent if she's acutely manic. So she may not actually be able to provide consent for either any tests or any treatment that may come. Also, in this particular scenario, and this is quite an extreme scenario, but I suppose I'm just presenting as a case to mark all the things that we need to address. But she's obviously manic and disinhibited and can't recollect what's happened. She's been found in the inner city, and it's been a few days that we don't have an account. So you have to then have a high suspicion that she may have been a victim of physical assault, but also sexual assault as well. And this is something we've had to kind of assess when we've determined as much information as possible. I've encountered a scenario when on call. I know there's clinicians from across Australia, but there's in each state there would be kind of a sexual assault unit based in different hospitals, and they've got 24-hour lines. So at the times I've spoken to the doctor who's on call with that service about whether it needs to be appropriate, whether the person needs to be examined, and in what particular timeline as well. It's also important to determine, because if we don't know what's happened over the last number of days, and there's evidence that she's become sexually disinhibited, that we determine if Amy's been on any contraception, and also whether the emergency contraception pill may be indicated as well. And again, this is an important kind of discussion to have in terms of assessing Amy's mental state, whether she can provide consent, but also the involvement of guardians as well. And also whether it's going to be appropriate to screen for sexually transmitted infections that she might have been exposed to. And also, importantly, that she receives the support and counselling regarding the above. And it's going to depend on the level of experience and expertise of the medical staff and nursing staff on the units to provide support. It might be a case of liaising with external supports to make sure that Amy's physical health is appropriately attended to as well. So that's quite, again, a kind of a extreme case, but it's something that we do encounter within youth mental health services as well. But what we're going to do is move ahead a number of months later for an Amy scenario, which might be something that happens that clinicians are presented with more commonly with in the community. So you're Amy's clinician in the community, and she's been discharged, and that was a 3-week admission. So following that time, her mental state managed to settle down, and her manic episode settled and resolved, and she's now back living with her foster family. However, since that episode, the relationships have been strained, and they're still concerned about her previous inappropriate behaviour. And they've observed a change in her behaviour. They've observed her to be sleeping more and staying in a room now more often. Her medications that were commenced in hospital were lithium, 1,000 milligrams at night, and also olanzapine, 10 milligrams at night. You've had, as your case manager, you've had a number of meetings with her, including some on the ward, and she's now got good insight into her mental health disorder, and she accepts the initial diagnosis of bipolar affective disorder, and that she's had a manic episode with psychotic symptoms. So in regards to her sexual health, what are the issues that are now important? So I suppose one of the first things is about psychoeducation. So and talking to Amy about that, some of those behaviours would be related to her mental health disorder, and being very explicit in saying that disinhibition is actually a symptom of psychosis, or it's a symptom of mania, and because that's important because there may be a number of blaming and stigma associated with it. So people can feel very guilty following a manic episode in regards to behaviours that they might have done that would have been very out of character for them. And also that psychoeducation is very important for the foster parents, because they might not have any understanding of mental health problems and not be aware that this is actually a symptom of an illness, and that they may have thought that this was just behavioural or inappropriate behaviour. And also it's important to talk about in psychoeducation about the risk of relapse. So we do unfortunately see high rates of relapse following a manic episode that can occur in the months, but also years after the original episode. And that's important to kind of emphasize the importance of continuing on medication, such as mood stabilizing medication, and also engaging in psychotherapy as well to deliver insights and also awareness of early warning signs as well. And it's also particular to be mindful and watchful for a post-depressive episode as well, and there's kind of indications that she might be becoming depressed or had been becoming more withdrawn. But it is appropriate and it's important to talk about when any young female has been prescribed psychotropic medication, to talk about contraception. In particular, in Amy's case, there's 2 good reasons to talk about it. Now, one is that we've established and know that there's a high rate of relapse in mania. So it'd be important to talk about a form of contraception that would actually provide her protection if she became disinhibited again and engaged in sexual activity that she wouldn't normally engage in. So that's one important factor. But the other important factor is that there can be teratogenic effects of lithium, so that there can be potential harm to the unborn baby, to the fetus, with lithium. So it's important that a person is recommended, if they're not intending to start a family, and again that's another issue on medication which we'll come to, and that they actually do take contraception as well. And again, this would be a good opportunity to engage Amy in with a GP or a sexual health nurse. And again, there's always this debate and talk about how much should be done within a youth mental health setting. We also have to think about whether some of these services are provided within the setting, or we link in with kind of external services. And I think what's important is that when you're that you establish kind of networks for the young person and a kind of support team that's going to last them for a long period of time. So if the person has an episode of care with the youth mental health service and all of their medications are prescribed from via this team, such as contraception, including contraception, then they when they're discharged from that service, they finish with that service, then they might be at a loss or feel disconnected. But it's a good time early on to link people in with GPs or sexual health services, so that they can have then ongoing contact with that service. Also, again, an issue that's kind of come up similar to the previous case, that when people have an episode of mania, that they at times they may be prescribed antipsychotic medication, which can be used to treat the mania. And again, raised prolactin is also an issue in this particular case. Less likely so with olanzapine, but still does happen, and it can have sexual dysfunction with that. But also there can be menstrual dysregulation, or lactation can also be a side effect. And again, this can be a very distressing side effect for females, and if they're not informed about it, they may not attribute to the medication, or they may not even bring it up in session. So it's important to ask directly about it. And also, as in a similar case, there's also other side effects of the antipsychotic medication, which may not be directly related to sexual health, the weight gain and sedation. That's important to address. So now, so you can see that there's the issues that need to be addressed in sexual health immediately on the acute setting, and then as things settle down, there's other issues which is such as long-term contraception and psychoeducation. And then what we're going to do is for Amy is now kind of skip forward 4 years and talk about that. Since that admission, Amy actually had one further manic episode which occurred 6 months after the first episode, and that resulted in a hospitalization. And this occurred in the context of her stopping lithium despite medical advice. But then following that second episode of mania, she restarted her lithium and has been compliant ever since then. And during that time, 2.5 years ago, Amy began a relationship which she describes as being loving and supportive. And she now has decided that she would like to have a child and would like to talk to her clinician about this, because she's still on medication. So again, so this is more looking at the kind of long-term implications and issues in regard to kind of fertility or family planning when people are on medication. So in this particular case, we'll talk about lithium, and we'll also then talk about antidepressants as well, because that can also be a case that arises. So what the recommendations are, and again, there's no major set rules in these scenarios, but it's always going to be a balance between weighing up, ensuring that the expectant mother receives the appropriate care for her mental health disorder, but also then minimizing any exposure of medication to the unborn child. And I suppose we know that there can be some effects on the fetus from medication, but we also know that if a mother's mental health isn't adequately treated during the time, that can also have an impact upon the pregnancy. So it is a balancing act between those. The other additional thing that's difficult is that there's very limited studies to inform us about this, because as you may have noted, in a number of the main exclusion criteria trials are if a female becomes pregnant, they tend to get excluded from clinical trials. So we actually have no, and that's appropriate, but we've no then good reliable information about the effect of medication. And where we get the information more from are from case registries or kind of large databases. And considering that a number of the side effects are potentially quite rare or uncommon, then it can mean that it's very difficult to reliably say that that's directly related to medication, because you need very, very large numbers. So I think that just needs to be taken into account when you look at the evidence and when you're discussing it with the client about the risks of either action. But we do know, in particular with lithium, that there can be an increased risk of cardiovascular malformations. So it's called Epstein's anomaly, which is abnormality in the tricuspid valve. So on what they found is, again, in the cohort study where they followed up women, of 148 who were exposed to lithium, there was a 1.2 relative risk increase for congenital abnormalities and 3.5 risk for cardiac abnormalities. Now, there's significant risk increases, but also that the actual risk in the general population, wouldn't be massively high. So but it does increase it some fold. And also lithium can affect the neonatal thyroid function as well. And again, in the limited studies, exposure to lithium in the second and third trimesters was found to have no increase in developmental anomalies. And that's important because I suppose then the risk of exposure with lithium can be timed. So one of the things they do recommend is, if possible, to actually before conception, to actually slowly taper lithium. And to kind of pick this at a time where there's low risk of relapse and diminished stress. So, for example, that it's going to be a period of time of holidays and not pressured events or exams or things like that. But one of the recommendations is to try and have the person not on lithium during the first trimester. If it does occur, what they tend to recommend is to have an ultrasound scan and echocardiogram should be performed at 16 to 20 weeks to look for cardiovascular kind of midline or other defects at that time. There's also the thing to think about is that if the person is stopped lithium during the first trimester, and if a relapse occurs, one of the recommendations is that antipsychotic medication is used at this time instead of lithium to help with the management of mania, as opposed to starting lithium. But again, as one of the kind of the first lines up there, it's always a balancing act between balancing the risk, the exposure to the unborn baby, but also ensuring that the mental health of the mother is appropriately treated. And it's certainly thought that lithium is safer than the anticonvulsant medications which are used as mood stabilizers. And it is stated that in the second and third trimesters that mood stabilizers can be recommenced if indicated, and it's advised to reduce the dose by 25% before delivery to prevent possible neonatal toxicity. And they should be monitored for this for up to 10 days after birth as well. Also, the other thing that's important to think about is that how long people should be actually treated for with lithium. So the guidelines that we have in Australia, so from the Royal Australian New Zealand College of Psychiatrists, they actually recommend that after the first one episode of mania that it's a minimum of 6 months treatment with lithium. But they don't actually specify then if there's been more than one episode, then it's still on kind of clinical judgment. But as you can see in the case vignette that we've had here, that Amy's actually been on medication despite one period of non-compliance, and she's been on it for between 2 and 3 years consistently at least. So it actually may be appropriate for her to have a trial of lithium. So again, that needs to be considered. And then the other thing that's important to talk about with females who are thinking about becoming pregnant and have a history of mental health disorder is looking at the postpartum period. Because we know that this can be an increased risk of relapse of mania or depression in general, due to, despite being a joyous time, they can also be in times of increased stress and also lack of sleep as well. And these are big factors that can increase risk of relapse. And we know that approximately 30% risk of mania in the postpartum period in women with females with bipolar disorder. And also, again, there's very limited studies in terms of breastfeeding, but it does indicate that breastfeeding it can result in high serum levels of lithium in the infant. So that also needs to be discussed about whether the mother intends to breastfeed, and then also, if so, what levels of is the medication expressed in breast milk, and the impact that could have on the unborn child as well. So these are all discussions that can only be done on a kind of individual basis as well. The guidelines, I'll give a reference to resources at the end, but guidelines that could give advice on this would be again the Royal College of Australia and New Zealand College of Psychiatrists, but also guidelines like the Moseley guidelines and the NICE guidelines would also give guidance on this as well. And I suppose the case that I've done is lithium, but in fact, medications that are commonly prescribed will include antidepressants. So we'll just include this, some information if in case this scenario was to apply for clinical scenarios where a woman who wants to get pregnant is taking antidepressant medication. I think it's important to acknowledge that according to the guidelines that they give the recommendations that actually it's not uncommon for women to actually be on this medication during pregnancy. So one study in the Netherlands reported 2% of women take antidepressants, and this was found to be as high as 10% in the US. But I suppose one study did indicate that there's higher relapse rates for those who have a history of depression, who discontinue their antidepressant. So relapse rates of 68% as opposed to 26% to those who stayed on the medication. So that's an important factor to consider, and it's important information to give to the female who's going to make this decision about whether they stop the medication or not. Because there can also be risks associated with antidepressants in pregnancy, such as preterm delivery, an increased risk of respiratory distress in the neonate. And while there has been some reports of congenital malformations, they have been reported as rare. And if we just look in particular at and the SSRI class of medication, because that's the most commonly prescribed antidepressant. And the data would indicate that fluoxetine would be one of the safer SSRIs to use during pregnancy. But a number of studies, the large kind of database or case control studies, have indicated its association between SSRIs and persistent pulmonary hypertension of the newborn. But that again hasn't been replicated. So a number of these findings haven't been subsequently replicated. But we do know that paroxetine, which is an antidepressant that's probably not prescribed as often now, is associated with cardiac malformations when it's used in high doses and in the first trimester. And we do know that there can be associations with SSRI use and having an earlier delivery, so on average by 1 week, and also a lower birth rate in babies to mothers on SSRI medications. And there has been case reports also of spontaneous abortions earlier in the pregnancy as well. So again, there's no, I suppose this is just information that that can be brought to the clinical interaction, and the information will be given to the client who makes then a decision in conjunction with their treating team about what's going to be the best thing for their scenario. And it's always weighing up a risk of relapse, the implications of relapse versus the impact of medication during pregnancy. And as mentioned, there's a number of clinical guidelines that can give guidance for clinicians on this. The Royal College is one, and they have guidance for affective disorders, bipolar disorder and schizophrenia, the multi-prescribing guidelines, and also the NICE treatment guidelines in the UK as well. And I might open it up and if there's any questions, but if not, I think I'll pass over to Georgina. Thank you very much for your attention, and I'm more than happy to receive questions by email and if there's particular issues that have been brought up.
Thanks very much, Brian, for that webinar. From my perspective, that was really interesting just to see how we can manage sexual health issues in different settings, from inpatient to outpatient, and then as the young person progresses through their life, and if they want to have a family and through pregnancy as well. So thanks very much for that. Just to let you know, we've got a range of workshops available on our national training calendar, and we can deliver and tailor them to your organisation and deliver them in your workplace as well. Okay, so thank you for your attendance at this webinar. As I said earlier, it will be recorded and put up online on our website, and it will be available in about 2 weeks' time. And you'll also get a certificate of participation, and an evaluation will be sent to you shortly. And we really appreciate all of your feedback to help us improve our webinars from here. So thanks very much for joining us today.